It's with great pleasure that I welcome Dr. Stephen Yip, medical oncologist and clinical assistant professor at the University of Calgary. His biography was so extensive, the September issue of the Digital Examiner only had a portion of his biography in there. That's all the room that we could fit. But what can you learn through Google? Well, believe it or not, I learned through researchgate.net. Yes, there is a thing, researchgate.net. I learned that Dr. Yip has authored or co-authored some 35 articles, conference papers, and most recently in June 2021, he authored an article titled Canadian Consensus Forum of Key Controversial Areas in the Management of Advanced Prostate Cancer. Recommendations for Canadian healthcare providers. Now, I didn't have a chance to go in and read more on that article. There was a path I couldn't get through on, but I'd be very interested to hear what he has to say. We're so very privileged to have Dr. Yip here to tell us more about his work and the recent announcement of the cancer detecting cyclotron for Calgary. So without taking up more of Dr. Yip's valuable time, we're so appreciate him making time for us tonight. I'll turn it over to Dr. Yip.
Great, thanks very much. So I'm a medical oncologist. I'm at the Tom Baker Cancer Center, and I'm pleased to talk to you today about personalized prostate cancer care in the advanced prostate cancer space. As I mentioned, with a focus in urologic cancers, I'm a medical oncologist, so I give systemic medications like oral pills or chemotherapy or hormonal therapies, often in the advanced space. And I have a particular focus and interest in translational research and genomics, as well as novel radiopharmaceuticals. And I'll just advance here. These are my disclosures. And so we know from a broad perspective that cancer treatment, it can be clumped into the primary categories that are outlined here. So we can think of cancer when it's in its earlier form, in its treatment with surgery, and we can cut it out, or we can give radiation, we can kind of zap it out. But sometimes therapy, it needs to be amplified to go anywhere the cancer cells could be, if it's more advanced or more spread in other areas. And sometimes this also adds to surgery and radiation. And so often in the prostate cancer space, this might be with hormone therapy. We also have targeted therapies, and we have chemotherapies typically in this realm, as well as immunotherapy. But we now understand that a one-size-fits-all approach doesn't necessarily treat all cancer for all patients. And each individual person has their own DNA makeup. So at the microscopic level, we understand that this is the blueprint that makes us who we are. And the human genome is 3 billion base pairs, which is, a basic science that's even more basic than I fully appreciate even today now. And it is the blueprint that creates the proteins that creates our cells and our organs. And cancer can result from a variety of different causes, but in particular can result from a change in the DNA sequence of our genome. And so if you imagine that if the blueprint gets somehow damaged, then that can certainly affect the plan and the scaffolding of the building or the person. And so if that change occurs in a critical gene, like an important pillar that makes us who we are, and that it can alter the function of how that gene will perform its day-to-day activity, it can potentially provide a growth activity advantage to the cell. And so cancer can result where there is unchecked growth of that cell. In particular with prostate cancer, that would be the prostate cells. And those causes of the DNA damage can either be at the level of inheritance, meaning your family members You may have had it passed along generations, and so you may have inherited this. And this is called a germline mutation or alteration to your DNA. Or it could have occurred sometime in your life, and this could have been spontaneous. It just happened for just an unknown cause, or it may be environmental due to a variety of risk factors. Oftentimes with cancer, we worry about smoking, drinking, and other chemical exposures that can sometimes put us at risk of certain types of cancer. So precision therapy is an approach that we're now embracing more and more in clinical care, in cancer treatments, where we try to understand the individual's DNA makeup and try to understand how their cancer might be driven. And we try to focus on that area that might give that cancer cell growth advantage. And we aim to identify it, attack it, and target it with specific therapies, and thereby avoiding more general side effects that we can see with more common use of treatments such as chemotherapy, which typically goes after more rapidly dividing cells. And as a result, that can affect not only cancer cells, but it causes other side effects because other healthy cells which rapidly divide can be affected, such as your hair follicles. That's why hair loss can occur. Sometimes it can be the skin, the bowels, and so on. You can find that this affects the blood cells in particular. So the goals of precision oncology are to focus on that microscopic level that might potentially give an advantage to the disease, and how we can harness this technology to target that with a specific treatment in a more elegant and specific way. The challenge is that every tumor is different. And in fact, if you just look at one individual patient, if you sample one cell, it might be a different type of cancer cell compared to if you sample it in another location. This is called tumor heterogeneity. As well, every cancer patient is quite different. So a one-size-fits-all approach doesn't necessarily apply, where we can just say all cancer is cancer and why can't we cure cancer? Well, it's because each individual is unique and each cancer is unique. And that creates major challenges of how we can treat this. So the goals of our molecular studies, which typically I focus on the gene, the DNA level, but there are a variety of different molecular studies that can be targeted that might be a focus of cancer care. The goals are to identify the changes in the gene and the proteins that are generated by the transcription or the decoding of that blueprint, and to identify new targets for that therapy, really focusing on those specific aberrations or changes to the DNA makeup or the way the DNA gets decoded. And we need to select drugs specifically where we aim to get the right drug for the right person at the right time and the right tumor. So if you imagine this as an analogy, you've got red cars and you've got blue cars. Well, blue cars might be the healthy cars. They're running just fine on the road. You've got red cars, they seem to all be broken down. We won't name any specific manufacturers, but we'll just say, if you look at all red cars, if they're all broken down, it might be for a variety of reasons. Now, assuming this isn't just a long recall related to a specific area, you could see that this could be related to a variety of different things, but you really need to look under the hood. You need to get that car up on the hoist. You need to inspect it, and you need to run analysis and figure out what is it that's actually wrong, because we can't just go ahead and hit it with a mallet and just expect that it's going to start working. So the summary of the cancer genomic studies that we currently have underway at the Tom Baker, as well as a variety of other research initiatives throughout Alberta, are to understand the biology of each cancer's disease and each patient's disease, to identify the novel therapeutic targets that will allow us to exploit these changes at the microscopic level, and to understand the mechanisms by which drug resistance can occur. So, a drug might work the first time you give it, but eventually cancer sometimes finds a way around it. And this is often the case in the advanced cancer space. And as a result, we see that this can develop with hormone resistance in the advanced metastatic space, or when people are on hormone therapy for long periods of time and there is microscopic disease floating around. The promise of the precision cancer treatment at the Tom Baker is as such, those approaches will guide us to select appropriate anti-cancer drugs to minimize the use of potentially ineffective therapeutics and minimize toxicities, and to deliver a personalized cancer treatment so that we're finding those individual microscopic changes that might be driving the disease and hopefully get better patient outcomes with less toxicity. This can be at the DNA level. It could be at, so that would be genomics. It could be at transcriptomics, the way that the DNA gets turned into proteins and so on. There's many levels in which we can interrogate and understand where cancer is being driven. So looking at advanced prostate cancer management, as I said, I mostly focus on advanced prostate cancer and systemic therapies. We understand that once disease has spread, either in the form of the PSA has come back after definitive local therapy, such as radiation or surgery, or there is disease that has spread, typically the backbone of the way we treat this is with androgen deprivation therapy, starving the body of testosterone and driving it down. And this is the major food source of the way prostate cancer can thrive. And so this can come under a variety of different terms depending on the state of the disease, but within advanced disease, typically it could be either biochemically recurrent disease, meaning PSA has come back. We don't see anything showing up on the scans. We can see non-metastatic hormone-resistant prostate cancer. So for example, the patient who has the recurrent PSA, it's going up, but they've already previously had their prostate surgery or radiation. And so we start them on hormone therapy, and then the PSA is still going up, but we don't see anything on the scans. But then we can develop metastatic disease. And that's when disease is spread outside of the pelvis to other areas, such as the lymph nodes or the bone. And typically, like I said, it will be sensitive to the hormone therapy, so metastatic hormone sensitive prostate cancer. But it eventually can find a way around this and develop hormone resistance, so metastatic hormone resistant prostate cancer. And that's just those little terms on the top there. And when we get into the resistant prostate cancer space, we need to start thinking about new ways we can really rev up the androgen blockade. And that's typically done by other avenues with medications such as abiraterone, enzalutamide in the metastatic hormone-resistant prostate cancer space. We can also think about apalutamide. We can also think about darolutamide in a variety of different spaces. This field is becoming increasingly more complex depending on how you fit in to this, but I'm mainly focusing here on the hormone-resistant prostate cancer in this decision tree. Typically, we have chemotherapy. We have other forms of chemotherapy, so docetaxel, cabazitaxel. We have other agents that we can use. And this field is growing and growing because there are other agents that are also in this field, such as radium-223 outside of Alberta. There's also other new agents called PARP inhibitors, which I'll get into. And then finally, we have other new therapies called radiopharmaceutical therapies that go after a receptor called PSMA. And these are, really cutting edge and on a little bit outside of what we have just yet right now in Alberta, but we're going to be bridging that gap and bringing those new therapies in the near future. And we do have clinical trials that are pushing to introduce new therapies that could be available to patients with advanced prostate cancer. And so we've understood that we could sequence this approach, we could go by that decision-making tree, but we need to understand the individual patient because more and more we understand that there is a lot more going under the hood. So we understand that there can be one of those DNA changes about 15 to 30% of the time in patients with metastatic hormone-resistant prostate cancer. So meaning that the disease has spread elsewhere despite being on hormone therapy, the PSA is still going up and it's progressing and worsening. Now, this can occur when it's inherited, as I said, that's a germline DNA gene mutation. And this is typically in the form of a gene called BRCA2. That's the commonest gene that could be affected. And this is an important gene that's used in normal function of the cell to repair the DNA when it gets damaged. And this happens regularly on a day-to-day basis in all of our cells. But for some reason, sometimes it can go unchecked. And so we need to put it back into check when we identify these kinds of changes to these genes. Other genes are outlined here in the pie chart, common ones being ATM, BRCA1, CHEK2. So you may have heard this from other people you've met with cancer outside of prostate cancer, such as breast cancer, ovarian cancer, pancreatic cancer. And really, prostate cancer was underappreciated for quite some time. And why is this important? Well, if we test for this and we identify it, it not only affects the way that we understand the prognosis of the disease, meaning how it might behave over the long period of time, the way it might affect other family members. So if you inherited it, potentially other family members could have inherited that same change. And then finally, it can inform therapies. And we'll get into that in a little bit. But how do we identify this? Well, right now, genetic testing is not standard of care. And we do have guidelines internationally to suggest that gene testing at the microscopic level should be performed with patients who have advanced prostate cancer. But we see about 400 patients throughout the province with metastatic hormone-resistant prostate cancer every year. And the testing is not cheap. And in a public pay system, it's very not feasible right now to test absolutely everyone. We need to identify patients who are appropriately high risk for this testing. Well, we could do this by doing a needle biopsy, but the problem is that, as I mentioned, that oftentimes when disease spreads elsewhere with prostate cancer, it often affects bone or lymph node, and it makes it somewhat challenging to do a biopsy. As well, it can be painful, you can get an infection. There are some risks to performing these tests, and especially when you try to put a needle in bone, well, it's like trying to tap a tree for its sap. You've got to be really, really savvy with that needle. And, chances are most people are probably not going to get it on the first go. And so it might be a bit challenging. Well, there's a liquid biopsy technique that's also possible. So we understand that the blood stream can be harboring and having freely circulating DNA, which is shed by your cells on a day-to-day basis, everyone's cells, whether you have prostate cancer or not. And this is called cell-free DNA. We understand that there's higher cell-free DNA concentration in cancer patients versus healthy patients. That's largely due to their tumor cells, which regularly turn over because they're rapidly changing and dividing, and as a result are shedding DNA, which is circulating tumor DNA. And so it can constitute less than 1% to 90% of the total cell-free DNA. This goes up as we have more burden of disease, we have more metastatic disease. And these changes are detectable in particular in patients who have metastatic hormone-resistant prostate cancer, more so than we would see in people who have early disease that's only localized to the prostate. So the aim is to sample the blood, put it in a vial. This is called a Streck tube. We then spin it down. We separate out the plasma and the leukocytes. And these are some of the constituents of the blood. And then we put it in the Illumina sequencing machine, which looks for specific genes that might be of particular interest, in particular the DNA damage repair mutations, such as the BRCA that I discussed earlier. Then we send it for bioinformatics analysis, and this can give us results and information about the DNA changes that might be specific to your cancer. And this is important because these changes can be exploited. So if you have, for example, a BRCA gene mutation, well, this is very important to DNA repair. And there is also something called PARP. So PARP is also important for DNA repair. Now, normally when both are functioning, anytime that DNA gets damaged, well, it can get repaired. And that is the normal function of all typical cells. Well, you can exploit this if the DNA is not being repaired well already in a cancer cell because a BRCA mutation might occur. And you introduce an inhibitor, so you inhibit the function of the PARP, and you have a PARP inhibitor. As a result, it increases what's called a single-stranded break, and then this starts to arrest how the DNA gets fixed. and it can encourage what's called double-stranded breaks. And as a result, this can result in the DNA breakdown and cell breakdown, and as a result, cell death. And by doing so, olaparib is a PARP inhibitor, which was looked at in a major phase 3 international clinical trial with patients who have metastatic hormone-resistant prostate cancer. And what was found is that patients who have these DNA changes, who have metastatic hormone-resistant prostate cancer, where they've progressed on medications that we typically use earlier on, called abiraterone or enzalutamide, or other androgen receptor-targeted therapies like darolutamide. And as a result, we can exploit this change, and patients were randomized to receive olaparib, the PARP inhibitor, or they got physician's choice control, oftentimes a pill or other agents. And those patients, here you see in maroon, this is a Kaplan-Meier survival curve, and you see a significant separation of these curves in favor of those patients who got randomized to receive olaparib, where you saw a median overall survival go up from 15 months to 19 months. So half of people might have lived longer than that on both ends of the scale, but overall, you're seeing about a 4.5-month improvement of survival, which is one aspect to consider when we identify these changes. We need to target it. And PARP inhibitors are one aspect. The other aspect is platinum-based chemotherapies. So chemotherapy, as I said, goes after rapidly dividing cells, but we can target a specific type of chemotherapy, which we don't typically use in prostate cancer, to those patients who have these DNA changes. And this is a pretty busy slide, but you'll see over here on the figure D, you'll have to take my word for it because it's pretty busy, but basically what we see is that people who get these BRCA mutations, their survival improves pretty similar to if they didn't have these mutations when they get targeted agents. So as a result, we're improving patients who might have more aggressive disease, we're improving their outcomes to be more similar to what we see people who don't have this aggressive kind of variant DNA change. We see that this also improves patients' survival on the second line after these hormone therapies when they get access to chemotherapy specifically targeted to their DNA changes, carboplatin in green here. So yet, despite this, currently genetic testing is not yet offered as standard of care in Canada. There are a variety of different guidelines in general. The NCCN and the ESMO guidelines are widely used guidelines that are often implemented and adhered to for a variety of different cancer approaches. And in particular, they typically recommend that patients who have advanced metastatic prostate cancer be offered testing at least for the inherited DNA changes. But as I said, this is very challenging to offer this, and it is, a major priority for me in my role as the Southern Urologic Oncology lead of oncology to bring that in the near future. Currently, how do we get access to genetic testing? Well, right now we're working blind for the vast majority of cases, but we have clinical trials at the Tom Baker, and the Prostate Center also has some trials. The trials that we are running currently are Capitello, Talipro, and Triton in this space, and this is an ever-expanding list. And will be growing, but specifically this offers DNA testing or some form of microscopic level testing. But the unfortunate thing is these trials are very stringent in how they let patients on, and so you have to meet a specific criterion. And as well, it's voluntary. You have to adhere to the stringent criteria of coming in every few weeks, and you have to be willing to undergo more intensive treatment and more intensive testing at the very least. So that could be viewed as a good thing or a bad thing, depending on your idea of quality of life and how much you want to necessarily see me in person. The referral to hereditary cancer clinic, our genetics specialist, is a possibility, but it's really not feasible for us to send all 400 patients every single year because we have literally one hereditary cancer geneticist who is in Calgary. There's one in Edmonton. I believe that's the extent of their specific geneticists in that field, but they have a team. But I would overwhelm them if I sent every single patient I saw to them. As well, that's only testing for those inherited genes. That's not testing for genes that could spontaneously develop or develop as a result of exposures. And then finally, mainstreaming genetic testing. Well, this is something that is in development, and it is primarily in fields like breast cancer or ovarian cancer. And it's our goal to also introduce that in the near future based upon clinical and pathologic criterion when we are particularly concerned that a patient might potentially be harboring an inherited mutation. And finally, there's the private or direct to consumer patient pay genetic testing options. This could be in the form of color genomics, which is testing for just those inherited gene mutations. There's Foundation One that could be in the form of, sorry, that's just my reminder to get online. Foundation One, which tests, the inherited mutations. And unfortunately, this is a cost to patients and is very challenging for us oncologists when we have a view that we want to treat all patients equitably and we view healthcare and health as a human right. So the lack of equity is a challenge. We are working on a variety of manners in which we can expand our resources that we could offer to our patients in the near future. One form is expanding the mainstream testing beyond breast, ovarian, and pancreatic cancer to include prostate cancer. The other aspect is with our POET, our precision oncology program, of which I'm a proud member, and the HTL group, we've been able to have a research-based genetic testing panel. And this is in collaboration with APCARI, which is the Alberta Prostate Cancer Research Initiative. And so we've been very fortunate to have a variety of these initiatives that are very collaborative and multidisciplinary to offer increased testing. But largely, this is still viewed as a research-based tool that will improve care, hopefully, and we will be looking forward to that in the very near future as we're just about to roll that out. The impact that we're hoping to achieve is to gain greater access to essential testing for more Albertans with advanced prostate cancer, and to guide treatments, in particular, greater access to specific targeted therapies like olaparib or PARP inhibitors or platinum-based chemotherapies, and to improve ultimately our patients' outcomes, and to advance the way that we treat these patients and our understanding of this disease, and to bring the new Calgary Cancer Centre to a major area of focus that will be internationally appreciated as a great center of cancer excellence. And with that, I'll thank all of our collaborators, our patients who have made vital contributions to all of this work, and all of my colleagues. And I'll answer any questions you might have. I think that there's also a question in the chat there.
Wow. I'm speechless. Usually I have a lot of questions, but tonight I have so many questions, I don't even know where to start. This is exciting information that you've shared with us tonight. And I guess one of the things that struck me is you sort of answered it later on about the availability of gene testing, and especially with the members of our warrior group and who are all going through recurrent disease of at some stage, and whether or not it's something that they could talk to their medical oncologist or urologist about here, whether or not they qualify. Would previous treatments be a barrier to the gene testing? So if you've had radiation and chemotherapy in the past, would that have an impact on your ability to qualify?
Yeah, thanks very much for that question. So it's very complex from which route you have to go, and ultimately, as our lead in the South, and throughout the province, I've actually outlined a proposed approach that we could focus on, particularly in the advanced prostate cancer space. So as I mentioned, like there's the clinical trials, which are quite stringent in what line of therapy, what prior exposures you've had to treatment you might have. So, generally, this is typically in the advanced metastatic disease space. So we have Capitello in the metastatic hormone sensitive prostate cancer space, meaning you've just had hormone therapy alone and you're recently newly diagnosed with disease that has spread elsewhere. Or there's, our TALAPRO trial. TALAPRO 2 is looking at patients who have had hormone therapy, but their PSA is going up. And it's called metastatic hormone resistant prostate cancer, and you haven't yet received certain agents. And so as a result, then you would be a potential candidate for that. And then there's the Triton 3 trial that is after that. So that's the second line in metastatic hormone resistant prostate cancer. And it's lots of minutia. You don't have to really need to focus on specific definitions. We have a collaborative group with the prostate center and with a radiation oncologist referring their patients to us. And so we're helping to guide the way for our patients and open up more doors. But that's just clinical trials. There's also, as I mentioned, there's the direct-to-consumer testing avenues where patients could consider pain. There's also other avenues that we can consider testing if it's very, very suspicious. So I didn't really get into the specific criterion that we're going to be publishing on in the very near future. But my previous collaboration with Dr. Kim Chi back in BC Cancer and our group, actually with Tulane University in Louisiana, we've developed a predictive tool to identify patients who are at highest risk of harboring these inherited mutations. And it'll actually be a calculator that we'll have as either an app or a website that clinicians can go to, enter in important clinical data and pathologic data, which basically means your age of diagnosis, other things like what was seen on the pathology, meaning like when they did the biopsy, what was seen under the microscope, and other variety of information, like if there's disease that's involved in the liver. And as a result, we can identify patients who really need to be prioritized, in which case I have to really bug the geneticists when my patients can't pay for it, I can't get them on clinical trial. Well, my next avenue is just to beg the geneticists, I know that it's not usual, but can you see this patient and maybe consider testing? But as I said, that's a bit of a challenge because resources are limited. But the more and more we see advancements in this space, now that we see that olaparib is Health Canada approved, once we see that it is now going to be funded, hopefully in the near future, then that will push our taxpayer system to consider testing to be offered as standard of care in appropriate circumstances. So there's a lot on the near horizon. My aim is to improve things currently, which I think we have some solutions, but it's very complex, to bridge the gap with these research initiatives, which are very near in the next couple of months. And then finally, to hopefully make this a standard of care resource that we can offer to Albertans with advanced disease.
Excellent. Warren, you had a question?
I think there were a couple of questions that were asked here. Maybe I'll go, I think a couple popped in my direct message. Or did you want to ask me directly, or I can just read them?
Just read them.
Okay, great. So is there evidence that prostate cancer is caused by a virus such as HPV? HPV can be related to other cancers. In particular, we worry about it related to cervical cancer. We worry about it increasing risk of certain head and neck cancers. We worry about some viruses with some of these diseases, but to my knowledge, we have not yet found a link between a virus increasing your risk of developing prostate cancer. Honestly, the greatest risk of developing prostate cancer is similar to the greatest risk of breast cancer. It's as we age, our increased hormonal exposures to our own body, and then our cells just typically rapidly divide in these organs, breast and the prostate. That's the greatest risk factor. So the vast majority of people, if they live long enough, will develop some form of prostate cancer. It's the rare situation that we develop it in the advanced disease space, or that it becomes this issue where we have to use all of these treatments. It's not extremely rare, but in most cases, it's something that might not necessarily limit your life. It might be something that you perhaps are found to have when you pass, but it might not have been the reason why you did pass in the end. So hopefully that is the case for the vast majority of us. And then with regards to can mRNA, so that would be messenger RNA technology and developed for COVID-19, be modified to persuade the immune system to attack the cancer cells. Well, I certainly don't pretend to be an expert in immunology and virology. As I said, I am in the area of new novel drug development. There has been a therapy that has been accessible in America with Provenge, which is kind of a vaccine viral kind of based approach treatment, but has been very costly and resource taxing, so is not funded in anywhere in Canada, nor is it accessible. But from the mRNA technology perspective, I'm sure that there's groups that are looking into whether there's some form that we can approach this from that microscopic level, the way that the DNA gets transcribed to the protein. There are a variety of ways you can attack it. The idea that you focus on the PARP is only one aspect that we could potentially go after that DNA. And so the other aspect is the platinum-based chemotherapy. But there are a variety of other ways. And so, more work needs to be done. And certainly many new therapies, I'm sure, are on the near horizon as we see, a strong signal there, knowing that the DNA can be often affected by patients. And does that answer those questions? Oh, sorry, there was one more question. If a patient pays for genetic testing, will the oncologist use the results? So that's a good question. Well, I think that sometimes, anytime a clinician orders a test, we try to order it for the purpose of it serving either to inform the way we'll treat or to inform our patients. So if it is going to impact care, then it is helpful. Sometimes it's a bit of a, really, did I want to know it? And so I would say that if you have advanced prostate cancer, I think that it would be helpful to know. And will the oncologist use the results? Well, I think that, I've had the fortunate and unfortunate situation of seeing both ends of the results. So sometimes I see people who have DNA changes that we can target, like the BRCA mutation. Well, Health Canada approval is for olaparib only specifically in patients who have what's called a BRCA 1 or 2 or an ATM mutation. So that's only 3 genes out of a variety of genes that they tested for in that study. And then there are even more genes, and it's a big heterogeneous group. I said that cancer can be heterogeneous and patients can be heterogeneous and varied. Well, DNA genes can be heterogeneous. But if we find that, then I can potentially get access to olaparib. I can potentially target it with chemotherapy in the appropriate circumstance. In the situation that unfortunately don't find it, well, at least I'm informed, and at least I know that I'm on the right track, that my usual standard of care treatments are more likely to work well. Because we often find that patients who have these mutations, the BRCA and ATM mutation, they might respond to some of our usual standard of care treatments, such as abiraterone or enzalutamide, but they usually respond with a short period of time. And it's a more rapid time when we start to see the disease starts to develop resistance and find a way around it. And then with regards to what does it cost for genetic testing privately, and is it available in Calgary was another question. So great question, and it really depends. So I do have a variety of different tools in the, a patient pays option. The kind of more comprehensive approach would be the foundation medicine testing, and that costs quite a bit. I'm not sure if I can actually state it in the video, but I would say it's several thousands of dollars, unfortunately. And there's other forms. There's ones that are just on that color genomics, and that's more in the hundreds range. Now, the in between is that there are some ways that we have local solutions available through our various collaborators here locally, and those are cutting down the cost significantly. Still thinking about thousands, but much less than what we see with foundation. And then, so it's kind of a varied, broad perspective. And that's why these discussions become so complex, and more training is necessary of our clinicians so we can help navigate and guide our patients. And so I think that medical oncologists, I'm a bit biased. I think we have a particular area of focus in this field, but there are certain specialists in this field who have academic interests at the Prostate Center as well, who could also provide further insights. And then another question was hyperbaric oxygen treatment. How can it treat metastasized prostate cancer? Interesting question. I actually don't know of any applications for hyperbaric oxygen treatments for metastatic prostate cancer. Our usual approaches are either chemotherapy, that was the first on the block, or our androgen receptor targeted therapies like abiraterone or enzalutamide, or radium-223, so these radiopharmaceuticals. And then there's also these novel radiopharmaceuticals that target a protein that's overexpressed on the vast majority of advanced prostate cancers called PSMA. And so that's called lutetium PSMA, which is also in the near future, and we'll have clinical trials in that space, and has been very exciting in this field. So to my knowledge, not on the near horizon. Those are the major ones that are currently in the mix in the advanced prostate cancer space. But there are other targeted agents that are coming about, and will be very exciting to see as we get more and more tools in our box. It'll make it even more complex of how we exactly personalize the appropriate treatment for each patient. And that actually leads to one of the questions about the cyclotron, I think, is what was being alluded to. How can it help? Is it mainly for imaging the gland and tumor? So it's a very complex question, and it's very difficult for the news to put it into a sound bite. But basically what a cyclotron is it helps us generate radiopeptides. So these are important pharmaceuticals that are necessary for imaging. And it's necessary for such imaging as PET imaging, so positron emission technology imaging. And oftentimes PET imaging is with sugar dyes, so FDG PET, but we actually have a PSMA PET. And PSMA PET, as I mentioned, PSMA being overexpressed on more advanced prostate cancers, allows us to have a more sensitive look and to identify disease that we would underappreciate with regular imaging, such as CT scans or bone scans. And this isn't yet standard of care in Canada. It is on the near horizon. It is FDA approved in America. But ultimately, the question is, what does it do to outcomes? We know that it's more sensitive, but it's just like doing genetic testing. If I did genetic testing on everyone, well, it might give me too much information. I have no idea what to do with it. So the idea is, I think that number one, we know that it will help us identify people who could benefit from the lutetium, the more radiopharmaceutical treatments in the advanced prostate cancer space, farther down in the metastatic hormone-resistant prostate cancer space. So if I identify with a PSMA PET that you have disease that has spread and it is mostly lighting up on a PSMA PET, well, it might likely benefit and respond to lutetium PSMA. As I said, that's on the very cutting edge and not yet in standard of care field, but that's the big hot area that we'll be expecting to move up in the disease course. And I co-wrote one important Canadian clinical trial group trials that will be activated in various centers throughout Canada and will be coming to Calgary, called the Pluto or PR21 trial. So that'll be challenging chemotherapy. It can also affect the way we identify disease when the PSA comes back. So you had a prostatectomy, you had surgery, or you had radiation, but the PSA comes up. So that's biochemically recurrent disease. Well, sometimes we wonder, is it just biochemical? Is it just floating around microscopically and we can't see it? Or are we just underappreciating it with our regular CT and bone scan? So in that situation, if we had a PSMA PET, sometimes we identify disease that has spread. And in that situation, that might guide our therapies. But the question is, if you intensify around that imaging, does that impact our patients' outcomes? So I was also, one of the co-investigators, co-primary principal investigators on a trial that will be coming in the near future that examines whether changes around your treatment in those earlier spaces of disease impacts long-term outcomes in as far as what's called failure-free survival, so living longer or time to development of disease worsening. Hope that answers it. It's a very complex answer to say yes, the cyclotron does help. It improves our access to PSMA PET imaging, which will be in the near future in specific situations with clinical trials. Our hope is that as we have trials establish PSMA PET and give stronger evidence in the space, the more that we can offer it in standard of care in the near future. It also affects a variety of other realms, but particularly in prostate cancer, that's how it could improve things. And it will help also in high-risk disease, hopefully, and that will also be examined in the trial. It can also impact other important diseases that are not cancer related and other types of cancers. So it is important in general for Southern Alberta and is an important resource for us to gain access to. And I think that was an overly comprehensive response to that question. But as I said, these are my complex areas and niches of focus. One question was also, is there a place for darolutamide post-chemotherapy? To my knowledge, I do not believe there is. Primarily, darolutamide is earlier, prior to chemotherapy. So that would be earlier on in the advanced prostate cancer space. Typically, after chemotherapy, we might be considering abiraterone or enzalutamide if you didn't gain access to it before. In Alberta, I think it's one of the unique provinces that allows you to gain access to two of these agents in the advanced CRPC or castration-resistant prostate cancer space. So largely we see darolutamide, apalutamide, enzalutamide moved up earlier on, especially particularly darolutamide and apalutamide earlier on in the advanced prostate cancer space. And then another question was, if a detailed PSMA scan can identify locations of active cancer cells, why can't you attach a drug to kill the active cancer cells? Well, that's actually a good question, and that's exactly what lutetium is focused on. So lutetium is basically targeting PSMA, and so it goes after that prostate-specific membrane antigen, which is overexpressed on the cancer cell surface. And so once it goes and attaches, it actually has a radiopharmaceutical that basically delivers targeted radiation. And as a result, can give more focused, more elegant treatment rather than, I can't give you radiation all to your body. I'm not a radiation oncologist, but, a radiation oncologist would never give you radiation to your entire body, because then you would, just unfortunately, your normal healthy tissue cells that make you would also succumb to the same effects of radiation. And that would be like, what would happens when we get exposed to major radioactive, Chernobyl-like disasters. You're not going to turn into the Hulk. Unfortunately, it's going to be overly toxic. But this is a much more elegant way that we can deliver it with minimal toxicities. So typically, those agents like lutetium or actinium or thorium, these are other agents that are all targeting PSMA. The goal is to minimize that toxicity, though you can experience certain toxicities because it can still hit areas where PSMA is expressed on normal tissues. And it can affect the salivary glands, so you can get dry mouth. You can also get your kidneys affected. You can also find that the blood cells in particular can be lowered, and you can sometimes get bowel symptoms, but generally pretty well tolerated. And compared to chemotherapy, a less toxic for most patients treatment option. And then another question was, I think that's it. I think I've got it.
I'm going to put you on the spot here and ask you if you had a wish list for the new cancer center. Is your wish list being fulfilled, or is there something else that you'd like to add to that you're not seeing?
Yeah, that's a great question. I mean, I could always have more resources at my fingertips. It would be great. Ultimately, I'm very privileged to be part of the Tom Baker team and to work with our great collaborators in Alberta. And I think we've done some important work to unify the entire province. So we have amazing resources in the molecular precision oncology field with POET, with AppCari, and I think greater support has been gained during my time here. We've gained important grants in support as a result of supports from such industry partners that have helped support some of this research that will allow us to gain greater genetic testing for our patients. Greater support has also been offered in the PSMA PET imaging perspective with philanthropic donor support. And so with this generosity, it has helped really push the needle and the pace in which we can advance the way we treat cancer, prostate cancer, and in particular, the way we understand and advance the treatments in this field right in the cutting edge area. So it's not just clinical basic standard of care, but it's really, we're contributing to the international field in this space. And we're participating across the nation where, I was concerned previously when I was in training, when I started my training out in Alberta, I was worried that we were a little bit behind, but I think that we're really making some great gains. And I think that we're on a great mark to make some great progress for Alberta. Ultimately, if I could have more, I'd love it. If I could have more support for POET to offer more testing for more patients, that would be fantastic. And that is our goal. And I think that we've been in discussion, in collaboration with philanthropists, with industry partners, with the ACF to improve this. And I'm very hopeful for further discussions and hopefully future announcements. Similarly, with PSMA PET, with the cyclotron, that's going to be a great improvement for our long-term benefit. But in the short term, the more support we have for studies in this field, the better, and the more independent we can be, and the more productive we can be, and the more we can impact people's care. So I'm very happy with the progress that we've made. I would love to do more. And I think that the sky's the limit. And with your support and with your engagement and with your advocacy, we're very excited to see how we can improve the face of the way prostate cancer is treated in Alberta and in the nation as well as the world.
Wow. Thank you so much for sharing your work with us tonight. What a great way for us to have our Prostate Cancer Awareness Month in September, to have you here and share this information. It's a very exciting time for our prostate cancer patients, members, to be hearing about what's coming in the new cancer center, but also the work that you're doing, and how much it's going to advance the quality of life for those men on their prostate cancer journeys. So we really appreciate your time, and I'm surprised that our questions we've got lots of time left, but
It's my pleasure.
that's good.
And if there's further interest in supporting these important initiatives, you can feel free to reach out. I think that right now the New Cancer Center is being supported by a variety of different avenues. My research and the work that we're doing is being supported by a variety of different initiatives, and I'm happy to provide further guidance and ways in which we can improve the field. Thank you.
Great. Well, if there's no further questions, then Dr. Yip, thank you so much again. We appreciate your time, and we'll let you get on to your evening. But thanks again. We appreciate it.
My pleasure. Thank you very much.
Thank you,
Have a
Doug.
great evening. Take care.